showed a month ago was a 6-year-old male who had some oral aversion, chronic bilateral knee pain, weakness, refusal to walk, and had some fatigue. The normal CBC ESR was high and CRP was normal. And he had these x-rays in the emergency room, and there was some osteopenia and maybe a little bit of metaphysical, lucency. We weren't so sure, but the thing in our minds were either it is a neuroblastoma or leukemia, something systemic process. I'll show you with knees, and they looked pretty similar. And since it was a systemic process in our mind, we did an MRI of the whole body to look for other lesions and to further characterize these lesions. And when we did the whole body stir, we saw, starting from the chest, bilateral, proximal humeri, metaphyseal lesions. Going on to the spine, there were multiple lesions in the vertebral bodies. And going into the lower extremity were, again, bilateral, symmetrically appearing metaphyseal lesions in the proximal and distal femurs and proximal tibia. So it was a systemic process, predominantly in the metaphysis. And there were multiple lesions in the pelvis, pelvic bones, and these distal femurs, there were some periosteitis and some soft tissue abnormality. And I'll show the T1s, they look like rather well-defined lesions. And to be able to determine where can we do the biopsy, we did a CT scan, and we couldn't really see a well-defined lesion. And patient was on the CT scan and had a cardiac arrest during the attempted bone biopsy, and had an echo. Echo showed pulmonary hypertension. And we also did a CT of the MRI of the head. They were negative. And because there was pulmonary hypertension, we thought there could be scolitis of pathology and a whole neck, chest, abdomen, pelvis CTA, and they were negative. And I showed the kids that we didn't know what it was going on, and we thought maybe it is CRMO, some other type of osteitis. And I'll show you something now. So patient had unequal vitamin C levels during investigation for the metabolic causes, and the diagnosis is scurvy. And the patient's diet was chocolate milk and Starbucks only. And he has some autism. I will show you the day that we had the conference. This was the Nail-Patella of medicine, a deficient diagnosis. And they were describing a scurvy case, which actually they also difficulty diagnosing. And their x-rays were a little more, maybe suggestive of scurvy at the time of the x-rays. There was metaphyseal lucency, and there's a little bit lucency in the cortex, and these metaphyseal extensions, which are called the Palcan spurs, and they can be associated with fractures. There's some periosteal elevation on their CT scan. And they also did an MR, and their MR showed more findings than our MR, and there was this periosteal elevation and subperiosteal fluid and periosteitis and edema. And another article, which was published in 2015, and they had 4 patients, and they all had restricted diet, and they described the findings of scurvy in MRI. And this one of their patients shows similar findings to ours, and again, they had this periosteitis and soft tissue. They summarized the MRI findings in scurvy, and they described diffuse and multifocal low T1, high T2, mostly in the metaphysis, but there could be other areas in the marrow, and they had varying degree of enhancement, which we know. And they demonstrated periosteal elevation and soft tissue signal abnormalities. So we did not know this antidemic. And then I went to Ron Henry meeting, and I was sitting down with Nancy Chauvin from Philadelphia Children from CHOP. And I was describing her, hey, we had this amazing case. It was so interesting. I was just describing the findings to her, and I said bilateral metaphyseal abnormalities. And she said, oh, was it scurvy?
Oh,
And I
wow.
was like, oh, okay, yes, it was. So they had 12 cases. So, but initially they also went through some difficulties in the pregnancy. It was the first case.
Yeah, so those well-defined lesions in the bones, the T1 weighted hypodensities, I guess, are those characteristic too?
Well, actually they don't really talk about much of the T1 findings. Mostly they describe these, they appear low density and maybe appear more well-defined on the T1 weighted, but irregular on the T2 weighted images. So that goes with the distribution of the abnormality, and actually got the biopsy, and biopsy did not show much, and it showed some inflammatory changes, and that was it. So
Okay, cool. Very nice.
very, very interesting case, I think.
You know, it's funny now that
Hopefully
now
more
that
people
you
will recognize the pattern and will be able to diagnose it without going to the extent of
well, it's funny you say
treatment.
this because now that you mention this case, I think we had a very similar case a couple of years ago, and we're scratching our head about. I'm gonna go look
Hi,
at that.
can you hear me there?
Oh, hey, Kieran, how are
It's
you?
Kieran here. Yeah, I showed 2 cases a couple of years ago, and when you were showing it, I thought of scurvy, but what put me off a little bit was those well-defined round lesions in the ischium.
Yeah, right.
The rest of it, when you were showing, I was thinking petechial hemorrhages and the metaphyseal. This looks like scurvy, but then you showed those, and I said, that doesn't quite fit. But so does that fit?
It did fit. It did fit in this patient, and the patient
Yeah, I
is.
have to include that patient, but did you find any other references for focal lesions like that?
Yeah.
No, Kieran, I was sort of mentioning this because we had a case. In fact, I asked the same question maybe before you came on about that same thing about those T1 weighted lesions that are round, and if this was really scurvy, and it sounds like it is, we had a case a couple of years ago, maybe last year, that looked very similar to these. Again, well-rounded lesions. I swore up and down that they should look for some kind of a malignant process like leukemia, lymphoma, but the kid did have a history of scurvy. So I'm wondering maybe it is, and it's just not.
Yeah.
It's just not known. I'm going to try to find that case for next month and show it. And maybe we can sort of point this out as a little case series that yes, all these other findings in MR are defined, but maybe more clearly or explicitly talk about these T1 weighted rounded lesions.
Fine ones, yes. And also pulmonary hypertension is actually a presentation of scurvy in this patient also. It has been described not as common as these bone lesions, but it is another manifestation of the process.
Yeah.
So this was a very, very interesting case, educational case. So I'm going to show you the other case, a quick follow-up. And the other patient was a 7-year-old male, had hip pain, blood septic joint, had the MR, and on MR we saw these findings along the medial aspect of the femoral necks, and I didn't know what they were at the time. They were like little folds, but they were really closely attaching to the femur, and here is in the coronal plane. And later we discussed this, and Mahesh emailed us, and he said, oh, maybe this is a plica. And when I read the article, and actually Dila also, we thought that it really fit with this Pectinofoveal Fold, and they described the dry appearance in 2009. And they're actually normal anatomical structures, and they extend from the medial aspect of the capsule to the femoral neck, or to the capsule inferior aspect. And this is the Pectinofoveal Fold, 75% joined to the capsule, but sometimes it's to the femoral neck of the femur. And they should be differentiated from the plica. It is a normal finding. And in adult hip arthrograms, about 95% of the cases, it is finding normal finding.
Yeah, as
learned
soon as I
from this
found it, I sent you that image that when we just did our arthrogram, and I said, hey, the more that I look at it, the more I see these things. So I was pretty confident that it was some kind of normal variant, or just a normal, not even a variant. The fact that it's 95% of the times, I should go and look and see if I see it that often.
I know, it is normal. So those are the cases that I was going to show.
Great.
And can move on. Thank you.
Thank you. That was great. Thank you very much for the follow-up. It's nice to get that, especially from month to month. It's a series of patellar lesions that sort of come across our desk in the last month or so, and it's nice because it sort of, for me at least, shows a spectrum of things that can happen in the in the patella. And so I'm just gonna. It's mainly a show and tell, not a lot of text involved at all. So here's case one, and like everything else that comes through our reading list, it's just going to be knee pain. I'm not going to give you the the age or the gender. So this is sort of the very characteristic appearance of this particular condition, where we look at, here's the radiograph of the knee, and if we sort of look through the distal femur, we see the patella outlined over here like so. And if we were to divide the patella into quarters like this and like this, we see there's a lesion in the upper outer quadrant that's relatively lucent, and on the MR we see that abnormality extends not just in the marrow but through the cartilaginous surface. And if we look at the axial des, which is sort of a cartilage sequence, we can see that the cartilage really is affected, and there's some invagination of that cartilaginous structure, really, if you will, into this lesion. And this is, of course, the very classic dorsal defect of the patella. So this came across, and again, important not to confuse this with post-traumatic osteochondral lesion or such and so forth. It's basically the form fruste of a bipartite patella, if you will. Bipartite patella is at one spectrum, and this dorsal defect is at the other. It may cause pain if there's irritation, if there's movement along the synchondrosis, so it's not completely painless. Here's case 2 on a similar theme. So here's a patient who came in again with knee pain, and we see again, if we divide this out, patella, that we can see through the distal femur, if we can divide it into quadrants, this also is in the upper outer quadrant, but not everything in the upper outer quadrant is going to be a dorsal defect. This happens to be in the upper outer quadrant. So on the MR, we see that there's a lesion in the bony part of the patella with some overlying soft tissue and bursal swelling, but the lesion actually does not extend to the articular surface. Here's the axial images, cartilage sensitive sequence again. Here's the lesion in the patella, but again, it does not have any effect on the underlying cartilage. So we know this is not going to be a dorsal defect. We didn't know what it was. Ended up being chromo. We did a bone scan and had other lesions in classic locations such as the metaphysis, and they actually biopsied this lesion in the knee, in the patella, and they got back chronic lymphocytic cells, and it was presumably chroma given the characteristic lesions in other locations. Case 3, another knee. Again, on the lateral, it's a little difficult to see, but there is a nice lucent lesion here. We missed this when we first looked at this. We call this a normal knee, but in retrospect, it probably is a little lucency up here. I don't have the frontal projection. I do, but it didn't really show it. But you can see the lesion over here in the CT. At first, we thought, well, is that a little nidus in here, and a little surrounding area of low density, suggesting. So we suggested maybe the osteoid osteoma. They biopsied this. It actually ended up being, here's the MR. Again, abnormal signal within the whole patella. Again, not really extending to the articular surface. A little bit of inflammation in the soft tissues and bursa anteriorly. This actually ended up being bacterial osteomyelitis of the patella. So a third case. And one final case I want to show you guys. Here's a relatively large lesion in the patella. Again, here it is on the axial in the sunrise view, with some overlying irregularity of the patellar surface, probably some soft tissue swelling also. We got an MRI. Now again, here's the lesion, not extending to the articular surface. This one actually shows, again, that bursal involvement, soft tissue swelling anteriorly, and even a little bit of soft tissue edema or fatty edema here in Hoffa's fat pad. And this ended up being an osteoblastoma. So the patella really is a unique piece of sesamoid or bone, and anything that can happen elsewhere can also happen in the patella. Some people have called it a metaphyseal equivalent structure. So things that happen in the metaphysis can happen very easily in the patella also. So there's my little whirlwind tour of what some of the lesions that just recently came through our door. Any comments, questions?
So the dorsal defect one basically always needs an MRI after those cases.
Right. In fact, it's funny. I was going to show one other case as a companion case. We had a osteochondral lesion in the femoral condyle, a big dorsal defect, and a loose body. And people were thinking, when they first saw this, could this have come from the patella? Maybe it was a lateral patellar dislocation or whatever. But it has such a characteristic location for a dorsal defect. We said, okay, this is probably coming from the femoral condyle, which is relatively old, so the cartilage piece didn't look like it matched up. When they went to arthroscopy, sure enough, there was a nice defect in the femoral condyle, and the loose body sort of looked like it fit in there, and the arthroscopic view of the patella had a very nice dorsal defect appearance with that, almost like that volcanic appearance of the cartilage as it sort of invaginates into the bone underneath, sort of like this over here, where the cartilaginous surface kind of goes into the bony part. So.
Yeah, nice cases, thanks.
Yeah.
Okay, so sorry, this was just following up the case we just had. This is the one I showed a couple of years back here, which was the Scurvy case. Femoral changes, and this child had presented with query Discoid Osteomyelitis. There's a metaphyseal change. You can see the periosteal reaction. And he also had scurvy changes of the mandible. So when you showed your case, I was thinking of scurvy, particularly with the petechial hemorrhages and the oral problems. But then when I saw those lesions in the ischium, that threw me off a little bit. So, Mahesh, you think you've seen those before? So
I think, I didn't know what they were because that threw me off too. And
so it's a 5-year-old male with altered weight bearing, and he had x-rays of the left leg, which shows this extensive lesion, really extending from the proximal metaphysis, sort of minor, not really expansion, but more scalloping, endosteal scalloping, in the proximal half of the femur. And then you can see this extension of the distal half of the femur with well-defined sclerotic margins and some small satellite lesions. Again, you see a similar change on the lateral projection. And then in his tibia, he has these well-defined cortically based lesions, which I'll give the answer away, but have a ground glass appearance. And so there's at least 2 of those lesions. So I guess these ones look pretty typical for fibrous dysplasia, but this one looks it looks atypical to me. I'm not sure what your thoughts are there.
Well, I always think of fibrous dysplasia as a long lesion in a long bone, and a lot of them are sort of flame-shaped. And so the first thing, before seeing the ground glass, I was thinking, could this be fibrous dysplasia, just because it occupies such a big portion of the bone, and it has, depending on what stage the fibrous dysplasia is in, can have that ground glaze appearance, loosened appearance, or sclerotic appearance. And so that's sort of what I was thinking.
Yeah, okay. And so here's the MRI. So here's the femur. There's sort of cystic changes proximally, and then there's a large cystic area in the diaphysis. And then this looks more homogeneous appearance, the lesion more distally. And here's pre-contrast. The cystic areas are sort of high signal intensity. And then post-contrast, the solid portion enhances, and there's just peripheral enhancement in the cystic component. And then if we look at the tibial lesions, they're relatively homogeneous, and they have diffuse enhancement. I had the bone scan, and that was really the only leg involved. There was no involvement. So you can see the 2 lesions. They got mild increased uptake in the proximal femur, but no real activity here. And he's got a fluid level in the femoral lesion. So is that something you would see with fibrous dysplasia? Plus, there's the scalloping.
I can't say I've really looked at fluid levels on fibrous dysplasia. Never really noticed it.
Only if there's ABC change, probably.
Yeah. Yeah, very good. So he went on to have a biopsy of the femoral neck, and it came back as fibrous dysplasia with ABC within it. So, that's good. That's what it was. Well done, guys.
Great.
So because you're so good at that case, I'm going to show you an unknown, and I don't know the answer yet because the biopsy is coming. They've done the biopsy, but I looked up and the result wasn't back yet. I wasn't going to show it, but since you got this answer, I will show it and see if you can tell me the answer here. So 3-year-old male with ankle swelling, and you can see that the bone looks relatively normal, but there's extensive soft tissue swelling. And he went on to have an MRI which shows extensive joint effusion, synovitis, and a florid synovitis. He developed a lump over the tendon, and he ended up having a biopsy of that lump. So you can see there's no real change in the bone marrow. The biopsy of that lump, and it came back as subacute necrotizing granulomatous inflammation.
TB?
I'm not sure. So that was at the age of 3.
Wow.
And then he's come back later, and this was his initial X-ray. I think they treated him with this as an inflammatory arthritis, and then he had steroid injections. Anyway, this is 2 years later now, so he's now 5 years old. And here's his initial X-ray, which maybe there's a bit of sclerosis here, but I would have called it okay. I don't think I appreciate it, except in retrospect. And then 3 months later, he had the X-ray that looks like this. And maybe you can see that lesion here, and it's got a sclerotic margin. It's fine. You see there's some almost collapse of the talar dome, and plus he's got some irregularity in the adjacent distal tibia. And he went on to have an MRI, which shows this altered signal. Looks relatively well defined, and you see there's extensive edema on the T2 weight images. And on the sagittal images, he has this lesion projecting anteriorly through the bone. So high signal T2, this soft tissue component projecting anteriorly, and it diffusely enhances. He doesn't really have that florid synovitis anymore, but he does have a bit of synovitis in his ankle and talonavicular joint. So
I guess does that the initial exam, the granulomatous changes, I guess that still makes me think things like TB or sarcoid
yeah, I guess, and it's 2 years later is the other thing.
Yeah.
So it's been going for 2 years, grumbling along, and I think you're right. We're thinking some funny inflammatory infective process, but it looked like that, and then 3 months later it looks like this. So it rapidly progressed, I guess, at this point.
Yeah.
So anyway, like I said, this is your chance to have the answer before I tell you the answer next month.
You'll think about it for a month.
Okay, you did. Sorry, they're my 2 cases now, so I don't know the answer, but yeah, we're thinking. Yeah. To be honest, if you just saw that de novo, you'd think about a chondroblastoma.
Yeah, especially the plain film.
Yeah, but it sort of looks to have progressed a little bit too rapidly.
Right.
Plus with that funny history before, and you look even on this one, there was no joint changes here, where he's got the joint effusion now, or the soft tissue mass, so that's developed in that time.
Right.
Yeah, I think it's got to be some chronic infection or chronic granulomatous condition of some type. We'll find out, hopefully.
So you guys are biopsying the bone lesion?
Yeah, he's already had the biopsy. Like I said, they've already done it, but unfortunately the result wasn't back for this meeting.
Yeah. Our episodes are like Star Wars episodes. There's always a cliffhanger.
This is it. Okay. Well, that's my cases.
Della, do you have any cases to show?
Actually, I have a question.
Yes.
This is Eric Padua in Oakland. With the fibrous dysplasia, has anybody ever seen bone infarcts in fibrous dysplasia?
That's a good question. I haven't.
You haven't? Okay, because recently I saw an adult case.
Uh-huh.
It was like the patient was in the 30s. Looked like classic fibrous dysplasia, but then it had these sclerotic serpentine look inside one of them.
Oh, in
Looked
MR?
like a bone infarct.
In MR?
MR, and I just wondered whether that can happen in a fibrous.
Yeah, I haven't seen it, to tell you the truth. I'm curious to see what other people have experienced on that or not.
No, I haven't seen that, but
Okay.
I guess it could.
Come up with any other diagnosis for that?
So it looked like a serpentine lesion in the fibrous dysplasia. So, I mean, could it be just active part of the fibrous dysplasia? That was, when Kieran showed his case, there were some areas of irregular enhancement. But were you seeing enhancement, or was it like stir bright areas of serpiginous bone?
Areas that were dark, like an infarct, and then around it was some bright areas on T2, like edema. But really, no. Well, it was a non-contrast scan, so it's hard to tell about it. But
well, maybe you could bring it next time.
bone infarct.
Maybe you could bring the case next time and show us. Maybe we'll have a better idea.
Right. Yeah, it would be a corollary case of it.
Yeah. Okay, great. Okay, so anybody have any other cases? Because I sort of showed my 4 cool cases.
An 11-year-old female, and the history was knee subluxus with extension. And you can see here there's, I've never called a Discoid Meniscus on a plain film, even though everyone describes the findings, I never quite get it. But she's got a Discoid Meniscus on the MRI, and you can see there's a degeneration of the meniscus, there's just a little bone cyst as well. And see on the sagittal projection, you see the Discoid Meniscus, and it's projected anteriorly, and there's no dorsal capsular attachment. And again, you can see it's sort of a mashed up discoid lateral meniscus with absence of attachment to the posterolateral corner. And here you see the abnormal signal, and it's sort of almost concertinaed, so you can understand why she gets that feeling of subluxation with extension. So it's moving around each time. So, yeah, I think this is a Wrisberg variant of the discoid meniscus with absence of its posterolateral corner capsular attachment.
That's great. You know, what's really interesting about this case is the plain film. Boy.
Goes back.
You can almost imagine a little soft tissue density there. You know, I mean, I would never call it, but you can really see the asymmetry now that you point out the discoid meniscus.
Yeah. So just a nice cute case, and now I definitely have shown it, so I won't have to show it again.
Okay, so this is a 13-year-old, and we obtained this, the orthopedic surgeon obtained this to evaluate. And so as we start looking through the axial images, there's clearly dislocated patella. And not only that, but the trochlear groove has not been developed, so it's a long-standing process. And you can see the articulating cartilage along the lateral femoral condyle has this configuration. So as we, let me just, okay, so here is the sagittal image. And so there are a few interesting findings. You can see that the anterior cruciate ligament, they're very hyperplastic or not, hypoplastic or not there. And so here we're medial, and I'm going laterally now. And so the meniscus laterally is containing this, it's like this ligamentous structure, and so we were trying to actually figure out what this structure is. And then medially, you can see that there is a discoid medial meniscus. So as we started to investigate the history, we had prior films on this region. And well, let me bring up the pelvic abdominal film, and you can actually see that there are these horns in the pelvis. So a Fong's disease. And so these are just MR imaging appearance on the knee patient that has Fong's disease. So we found it interesting. And when we looked it up, what's described is either extra ligaments or there are plica. And actually, a plica going right along the midline is described. And so I'm not sure whether the structure that we're seeing is actually a plica. And apparently, when they look arthroscopically, a lot of the articles that I looked at for this separates the lateral from the medial compartment, and that's why the patella is deep all the way over to laterally. So this was just an interesting case.
Oh, that's great.
MR of the knee in a child with Fong's disease.
So is that abnormal appearance of the cartilage on the lateral femoral condyle because the patella now articulates at that place and not at the groove?
That's exactly what we're thinking, because there is no normal trochlear groove, and so because of the particular and long-standing, so it's exactly what we thought.
Oh, that's great.
Yeah, nice case.
Awesome case.
Has everyone ever seen anything like that? Have you ever done an MR for Fong's disease? And you've seen that? We were really struggling with that ligament and trying to figure out whether this was ligament or plica. That and actually you can see that where it inserts into the femur, that it's actually completely denuded of cartilage.
Yeah. No, the only other ligament I've seen, not necessarily in Fong's, an accessory ligament, has been the true anterior meniscofemoral ligament, but that typically parallels the course of the ACL. This is clearly something else. It's amazing. All right, gang.
All right,
Thanks
thank
so
you,
much.
Okay, thanks guys.
Bye.
Bye.